Hello, everyone. Welcome to the Center for Telehealth and eHealth Law. We are grateful to have you here with us today on Wednesday, May 28th for our webinar with Patrick Cunningham. Today's webinar is titled Medicare Enrollment and Reassignment for Virtual and Hybrid Care Providers, Architecture and Execution. Patrick, welcome, and we look forward to your presentation.
Thank you, Krista and team. It's wonderful to be here today and really appreciate all the great work that CTEL does in order to support so many parts of the broader virtual care and telehealth community in so many different areas. By way of introduction, I was an early employee at Onduo, which was a national virtual diabetes clinic. Where I was responsible for setting up their nationwide legal, financial, and operational architecture, and have recently, over the last few years, been consulting with virtual specialty clinics on their architecture, including Medicare Enrollment and Reassignment. The complexity of virtual and hybrid in the context of Medicare fee-for-service are an area that I'd love to share some of my learnings with the team here today. So with no further ado, I'll if I can get my technology to accommodate, I'll begin. So for traditional brick and mortar is fairly straightforward, where we have the provider group and legal entity, provider location, employee and contractors and patients that are all physically located in one geography, and that is simplifying for the vast majority of how healthcare is delivered today. As we certainly during the pandemic, as telehealth advanced and more organizations moved to virtual and hybrid operating models, the structures to operate over a much larger geography required the multiple legal entities in order to operate broadly. And so with multiple legal entities, often with the contribution of a managed services organization, various owners, now more locations, including home locations for providers, and those staffing, that staffing being distributed across a broader geography. This has created a much more complex environment for these virtual care organizations. Certainly relative to the brick and mortar models that have dominated. As it relates to Medicare, there are more kind of structure and requirements around the enrollment and reassignment, and more structure than exist within the kind of commercial or employer space. So with the friendly PC structure, so I'm going to focus on this focus on Medicare for a moment, understanding that different lines of business have different requirements around their enrollment, around their credentialing, and other associated contracting. I find that this model here with a friendly PC organization highlights some of the challenges that existed for Medicare enrollment and reassignment. You'll have the multiple legal entities here that exist. You'll have multiple providers that are now no longer associated in a one-to-one relationship, but are now across a number of different geographies, including delivering care from their home. The way that Medicare is administered is via different Medicare Administrative Contractors, the MACs, and they're assigned different geographic regions, in order to process claims and engage with providers for servicing Medicare beneficiaries in those different geographies. So even as a federal program, the individual MACs are the ones that are responsible for processing, for enrollment, for reassignment, and for processing the claims that come from these individual providers. It's this kind of disconnect that exists with multiple providers, multiple entities, multiple locations, and multiple MACs that has created confusion among many in the virtual care and telehealth community, where it's unclear where providers need to enroll their individual entities, enroll their different providers, and how to make sure that the claims that are getting submitted are getting submitted properly. So what has the tie-in, of course, for many of these claims is that even as we have the contractors at the in these jurisdictions, the payment rates exist at a much in 112 different payment localities, and those geographic payment rates are vary across all parts of the country. And so for an individual patient that might be seen in one city, who is seen by a provider let's say San Francisco, or a provider that's seen, let's say, in Missoula, Montana, the payment rates for that same telehealth visit are going to vary even for that same telehealth visit. And that's a bit non-intuitive for those that often focus on the location of the patient for reasons related to the corporate practice of medicine or state medical licensing. But it's that often that disconnect where the location of the provider is what is critical for the reimbursement of that visit. Moving forward here, building up to where their different requirements are for virtual care, taking a moment and looking at how brick and mortar organizations structure their enrollment and reassignment is a helpful starting point. So in the example of Maryland, the MAC for Maryland is Novitas. In the brick and mortar example, you'll have Jones Medical Group as a legal entity with a location at 456 Elm Street, will enroll with the MAC, and then a provider, in this case Dr. Smith, who works at this physical location, at this practice location, will then reassign their benefit to Jones Medical Group within Maryland. This is the very linear and integrated model that you saw on that first slide for brick and mortar care. During the pandemic, when many providers were no longer going into the office in order to deliver care, and were instead delivering care from their home addresses, this created a bit of an issue, because no longer were the providers going to the physical address for Jones Medical Group, but were instead using their actual home location. And so depending on whether or not that location was within the same MAC, or was within the same geographic region for pricing, that created a bit of a kind of administrative disconnect for the requirement, for the enrollment and reassignment requirements. in different comments to CMS and different advocacy to CMS. CMS allowed for the currently enrolled location for these individual providers to maintain that enrollment and reassignment. So they would not. So these providers during the pandemic and now through the end of 2025 would be able to use their currently enrolled location for the purposes of enrollment, reassignment, and billing. What we have, though, in many new virtual and hybrid organizations that were no longer did not exist at the beginning of the pandemic, or that have added new locations, added new providers, or are no longer operating within that waiver, is a bit of the challenge that a lot of folks that I work with have run into. And instead, for these medical groups, are now have the requirement of listing the locations, these practice locations for each of the individual providers, for the group enrollment and for billing. So the group will certainly enroll, the same group, Jones Medical Group in Maryland, will enroll their location. But as well, if these providers are providing virtual care from their home, they're also responsible for adding that practice location to their individual enrollment on the 855I, but as well adding that practice location to the group and for the purpose of the billing. And so the number of practice locations that exist are going to go up considerably by virtue of the requirements that Medicare has regarding the listing of the location of the provider at the time of the visit for the purposes of enrollment, reassignment, billing, and payment. Interestingly, this large number of practice locations will increase substantially the tracking and the other let's say EMR and revenue cycle systems that need to be in place in order to make sure that the appropriate claims, that the appropriate information are being included on all the claims that are going to the local Medicare MAC. As we kind of push the models a little bit further, not all of the providers working for virtual organizations may not solely be included in a single state of that provider group. Noridian, as recently as last month, has provided very helpful guidance and examples around how to treat this complicated enrollment and reassignment conundrum for a lot of virtual care organizations. And so what they've highlighted here is for virtual or hybrid organizations within a single MAC jurisdiction, let's say in Montana and then in South Dakota, that are both supported by a single MAC, single jurisdiction, Noridian. The provider, again, this Dr. Smith, will list will include their home address in the this Dr. Smith, who's providing telehealth services from their home, will reassign their benefit to Jones Medical Group, Jones Medical Group will list not only their location in Montana, but as well the home location for Dr. Smith in South Dakota. The claims that are submitted from Dr. Smith will have the Dr. Smith's home address as part of that claim, and then be paid according to the geographic price cost index that we saw earlier. Moving forward still, and this is what's caused an even greater confusion for virtual and hybrid organizations where they don't have brick and mortar in these various states where providers are located, is that you'll have now Dr. Smith, who's located in South Dakota. If Jones Medical Group has no physical location in the MAC, it begs the question: how does Jones Medical Group enroll within the MAC so that Dr. Smith can complete that reassignment? In that example, what again Meridian highlighted last month is that the Jones Medical Group will use the address of the provider, that is the home address for the group enrollment, so that they can complete their enrollment on the 855B, and then Dr. Smith can then further complete their reassignment to the group also at the same home address. And this model is what is now necessary for a number, again, new and hybrid group enrollments, in order to make sure that the claim that Medicare is paying for the claims at the rate of where the providers are located at the time of the visit. It's needless to say, it's quite complicated, but these are some of the disconnects that exist between brick and mortar care, where everything is co-located, and now in kind of virtual and hybrid care, where there's a much broader distribution of the groups and entities, and staffing for those individual components. The MACs, as they're supporting different providers, have provided helpful guidance to the two different groups, and have highlighted in again recently as last month some areas that are where they've seen a number of different errors. And in my work with different telehealth organizations, this is a common error where organizations are enrolling their providers in all the MACs where the provider is licensed, confusing the medical license kind of state-based framework with the Medicare MAC enrollment framework. That's a no-no, and it creates unnecessary complexity in that process. Some of the other elements that also cause confusion are the use of virtual offices, such as kind of a UPS or a Staples, in order to create a physical location in a particular geography, that creates scrutiny from CMS, from the MACs, for a site audit, and then the risk of losing one's billing privileges as a consequence. These are some, but not all of the complexities that that the MACs regularly encounter, and certainly I've seen when working with different virtual care organizations and distributed and national care organizations as they go about properly enrolling and reassigning in Medicare, so that to participate in traditional Medicare. And so just bringing it together here for a moment, is that unlike the brick and mortar models that have dominated healthcare delivery for so long, these now virtual, hybrid, and distributed models are much more complex from their kind of legal underpinnings, from their kind of distributed locations, and from certainly providers that are, again, much broader, and often that have multiple licenses, and or as many as 50+1, in order to be able to serve Medicare beneficiaries broadly. It's these many relationships that often create friction and conflict with how Medicare and other healthcare technology and services have been administered historically. That is what is challenging for a number of innovators in the space. What I found is that being very efficient in the design, understanding the landscape of how healthcare is organized, how it's paid for, is necessary in order to be able to design and implement the appropriate enrollments, the appropriate reassignments, the appropriate models to be able to launch and to scale within such a complicated environment. These are some of the kind of the challenges and complexities that I enjoy about virtual care, and certainly happy to answer any questions from this group about some of the complexities therein.
Hello. Hi, I'm Carol Yarbrough. I work at UCSF Health.
Mm.
Hi, thanks for your presentation. It's always nice to hear that Noridian is actually, they've caught on how to do this correctly. My question is, if you're a virtual provider without brick and mortar, and you want to provide CCM or chronic care management, or any of the new PIN codes, which are of course not telehealth, but require a place of service 11 code in order to bill. I know certain companies have contracted with brick and mortar in order to do this. I'm revisiting on applying for a new virtual clinic place of service code on behalf of, I don't know, out of the goodness of my heart, really. Just because it's so complex to be able to do this. And if you're fully virtual, the whole task of partnering with brick and mortar, making sure that brick and mortar person gets licensed in the multi-state locations that you want to provide CCM.
Yep.
Instead of having your own fully licensed provider, overseeing multiple things. I mean, if that's your take as well, I've had some, Max say, well, you should bill where the patient is, like or well, how about this? So home health care. Here's a better one. Home health care. They have no clinic because it's a home health care office, and they go to patients' homes or to assisted living centers, which are essentially patients' homes.
Mhm.
I had a Mac tell this person to go ahead and bill place of service 11 because that's what was required in order to get paid. So they've documented that response. It's not a great response. These are in-person services they're providing in addition to, they just don't have a clinic.
Mhm.
They provide all home health care. I mean, house calls. It's a
Yep.
house calls. So
I think that it's there's certainly a number of edge cases that exist between a lot of the guidances in the kind of internet only manuals that whether it's in the claims processing manual or whether it's the program integrity manual that are kind of anchored on brick and mortar care and virtual, whether it comes to PIN, CCM, COCM services that assume incorrectly that that it's not done virtually
yeah,
is a bit frustrating. Some of the conversations that I've had with the different Macs, depending on the different reviewers that you work with, is so even some of them are not as familiar with how the enrollments and reassignments and kind of and the various legal entities, whether it's a California entity, somebody who's licensed in California operating in New York, but seeing a patient in California needs to have the California entity kind of qualified in New York and then enrolled in New York so that the claim is submitted properly. That those mechanics are unfamiliar for a lot of Macs, and working with them in order to working with the virtual care organizations, working with the Macs in order to explain and outline what is necessary. It, is what I've found to be most helpful. Otherwise, it can get again too complex for everybody.
so applying for a new place of service code for a fully virtual clinic, I mean, the guidance I've read is like, oh, they still believe people need to come to the clinics, da da da. Uh, but I don't know if you're a Medicare Advantage patient, they support telehealth without the flexibilities than they did before the pandemic. So it's just a conundrum, and when you're telling, burgeoning and new vendors about, well, this is what you need to do for this type of insurance, and this is what you need to do for this Medicaid, and this is what they're just kind of mind boggled. And, and that's why you say you just pick Medicare and go with that because then you're covered for everybody more likely than not. Um, but anyway, I just some comments, I guess. And would you at all like consider the filing or a request for a fully virtual clinic to be receptive by CMS, by Sandy Harshman, or do you think it would just be kind of a fool's errand?
I, I think that um, I'm,
In your experience, just an opinion. I'm not going to hold you to it.
yeah, I think that the rules, while not the rules as they exist today, still work for virtual care. It's a little more cumbersome, but I need to understand a little bit more to have of a virtual clinic place of service that's distinct from a virtual
To allow them to not partner with a brick and mortar, that they could provide CCM
mhm.
using Place of Service 11. So it'd be a non-facility and or virtual, maybe asking for an amendment to Place of Service 11. I mean,
Yeah.
it's not a facility, so why not? I mean, they did add street place of service 27 a couple of years ago for street medicine, street place of service.
Mhm.
Uh, so why not fully virtual? It's just one more step. There's no office. You're on the street. It's face to face,
Mhm.
but anyway, it's like the next step, or maybe an amendment to place of service 11. I don't know.
Perhaps. No, there's we're still navigating and kind of improving some of the
Yeah.
policy virtual care. Yeah, and it's one step at a time. Are there
Thank-
other questions? I do that
I think
Yeah,
we're
I've got one for
sure.
you, Patrick. So Jonathan Neufeld, I'm a director of one of the telehealth resource centers located at the University of Minnesota. And I had to join late, so I'm going to take a risk here and ask a question, and I apologize in advance if you answered this within the first few minutes of the presentation, but we, from time to time, get questions that have to do with jurisdictional kinds of questions and reassignment kinds of questions. And we have rarely, not often, but rarely had conflicting advice given by two different MACs, because one of the states involved is with one MAC, one of the states is with another. They say it's the other guy's fault. No, you say they have, that situation.
Yes.
Is there, and we've asked this before, and we've gotten, well, is there an authority in CMS, someone to whom one can appeal at that point and say, look, clarify this for us, because we're getting conflicting advice from the MACs who don't always, truth be told, understand the policies under which they're operating in virtual care space.
Um, Short of there's not authority that I've found. The providers are kind of pointed to the local MACs and their jurisdiction. And you're right that some of the MACs have given kind of conflicting and incorrect information as it relates to various various elements related to virtual care. That's really frustrating for a lot of organizations that try and go to the local MAC and receive local MACs plural and receive conflicting advice. I will say that some of the language around kind of the interjurisdictional reassignments benefits, which is at the intersection of two different MACs, is very clear and delineates what the requirements are for each MAC on either side of that equation in order so that the provider's claims are accepted, processed, and paid correctly, even if it's unfamiliar for them as they go about their day-to-day business. The example that I had a second ago for a California licensed doctor operating in New York who needs to reassign to their California group now in New York, is just one common example, because a lot of virtual care organizations have a domestic PC and just for California or just for New Jersey or what have you. Being able to explain that to the MAC is, I find, helpful, to the MAC reviewers, helpful, so the enrollments and the reassignments and claims are processed properly.
Yeah, that phrase, explain that to the MAC, that's a tricky one. Doing a lot of work in this paragraph, right? I mean, I take your point, and maybe I will have to engage you as a hired gun next time it comes up.
I've kind of sat shotgun for a lot of organizations as they do go to the max. I'm a visual learner, and some of those schematics, these are the simple ones. There are more complicated ones still when you kind of overlay on top the number of for example, if you have one person, going back here for a second, if you have one person, one provider who's licensed in 51 states, that now needs to reassign to all the different entities, in order to be able to support a national operating, like delivering care nationally, that is complicated. And so it's with those individuals that have multiple, like 10s, 20s, 50 plus licenses, and that are working for 1 to 5 more entities in Medicare. That's where it's helpful to have the right architecture and design at the outset, so that have the right architecture from the outset to avoid some of the frictions and on the Mac side or on the internal RCM side.
If we don't have any more questions, we're going to wrap up because we're a bit over time, but we wanted to thank Patrick for an amazing presentation. And anyone that is interested in speaking to Patrick can reach out to him directly. He provided his contact information on the last slide. And if you're unable to reach out to Patrick, feel free to reach out to CTEL at info@ctel.org, and I'll put you directly in touch with Patrick. Thank you again, and looking forward to seeing you at the summit in just a few short weeks. Thanks, everyone, and take care.